Hello, my name is Melissa Rudy, and I am a first-year internal medicine resident at Ohio Health Doctors Hospital in Columbus, Ohio. I will be sharing a case report on how abnormal CBC findings led to the diagnosis of chronic eosinophilic leukemia. 53-year-old male presents with a 3-day history of vertigo, nausea, and vomiting. Complete blood count showed leukocytosis and thrombocytopenia. Manual differentiation revealed neutrophilia, hypereosinophilia, and monocytosis, with the presence of myelocytes and metamyelocytes. Eosinophils made up 20% of the differential, concerning for myeloproliferative disorder. Peripheral blood smear showed neutrophilic leukocytosis with left shift, eosinophilia with occasional hypogranular forms, and thrombocytopenia. Figure 3 depicts a normal eosinophil in the lower right corner and an abnormal eosinophil with depleted granules in the upper left corner. Bone marrow aspirate showed markedly hypercellular marrow with myeloid immaturity and morphologically abnormal eosinophils. The bone marrow differential included 5% blast, 15% promyelocytes, and 7% eosinophils. This figure depicts 3 eosinophils in the center, surrounded mainly by promyelocytes. Bone marrow core showed mostly maturing neutrophils and eosinophils. The eosinophil precursors had decreased or unevenly distributed granules. Fluorescence in situ hybridization did not detect any abnormality in the platelet-derived growth factor receptor beta, the fibroblast growth factor receptor, nor the AVL proto-oncogene 1 or 2. Instead, 83% of the nuclei had deletion involving the CHIK2 gene region and had retention of the FIP1L1 platelet-derived growth factor receptor alpha gene region. The final classification was chronic eosinophilic leukemia with rearrangement of the platelet-derived growth factor receptor alpha gene. Our patient was started on imatinib therapy, and all cell lines normalized after 3 months of therapy. Figure A shows deletion of the CHIK2 in the bottom left corner with lack of the orange probe target. In Figure B, 3 months after treatment with imatinib, there is no longer any evidence of CHIK2 deletion. In conclusion, our patient presented to the emergency department for nausea, vomiting, and vertigo. He was ultimately diagnosed with vestibular neuritis for these symptoms. It was when the manual differential came back from the CBC that was ordered in the emergency department that the team became concerned for a myeloproliferative disorder. It is through this careful and deliberate interpretation of routine lab work that dangerous pathology can be diagnosed and treated in a timely manner. Below, I share a list of my collaborators and included my references. Thank you for your time and consideration.